to the rehab for CMC arthroplasty. First of all, just a quick description, and Dr. Ackerman went over it. It's removal of the trapezium combined with the use of usually the flexor carpi radialis tendon into the empty space, and it's treatment for advanced CMC arthritis of the thumb joint. So what is the best rehab for CMC arthroplasties? Well, actually, there are no studies that compare the specific protocols. There are a lot of different protocols out there, but there's none telling us which ones are the best or what's the best way to rehab this. The protocols varied widely between institutions. Immobilization, some were immobilized for 12 weeks without any motion for 6 weeks, some cast for 8 weeks, and some started motion at 2 weeks and discharged the splint at 8 weeks. The Hand Rehabilitation Center of Indiana at 2 weeks transitioned them into a forearm-based cast or thumb spica splint, and then would begin active and passive range of motion of the thumb at 4 weeks. 6 weeks began gentle strengthening and then discharged the splint at that time. The Hand and Upper Extremity Rehabilitation, a practical guide, would start active and passive range of motion of the MP and IP joint only at 2 weeks, and then active range of motion of the thumb specifically at 4 weeks, and strengthening at 8 weeks. There was a paper by the Journal of Hand Surgery in September of 2016 titled Early Mobilization After Basal Joint Arthroplasty, and they had 2 groups, 27 patients total. Both groups were immobilized following the surgery in a thumb spica cast for 2 weeks. And in the first group, they did more of an accelerated rehabilitation and transitioned them into a removable neoprene thumb splint and allowed them activity as tolerated. The second was more of a traditional rehab, and at the week 2, they put them in a thumb spica cast or splint, and they had them wear it full time for an additional 4 weeks before they began range of motion strengthening. The results really showed no statistical significant differences between the 2 groups with respect to age, either post-operatively or preoperatively or post-operatively for DASH scores, visual analog pain scores, pinch and grip strength, or thumb range of motion. And they found really the same non-statistical significant differences at 6 weeks post-op or 12 weeks post-op. And so there was no interoperative complications either. And this is just a title kind of, tables representing that data. So really what they found was that the early, at 12 weeks, early suggested that the early mobilization of patients following CMC arthroplasty had no compromised clinical results. And so really what they hypothesized that they would still get those same good clinical results whether they held them and moved them later or did more of an accelerated rehabilitation protocol. So with that all being said, I'm just going to kind of go over what we do as far as our CMC arthroplasty protocol at the bone and joint. We'll see them at the first post-op visit at 10 to 14 days, and we'll do an initial evaluation, evaluating their pain, looking at their incision edema and some functional range of motion and quick dash measurements. Our treatment will include addressing scar issues, desensitization if that's needed, and any edema control issues. We'll fabricate either a forearm-based or a hand-based thumb spica splint, and that's based primarily on physician preference. If the STT was also involved, we would always then use the forearm-based splint. The big thing about the splint fabrication is making sure that we keep the MP joint in 30 degrees of flexion in that fabrication, because the MP joint has a tendency to be hypermobile anyway, just due to the progression of the CMC arthritis itself. We instruct the patients to use the splints most of the time, except for exercise and hygiene issues. During that first post-op visit, we will have them do exercises to start off that are non-threatening to them, including IP joint range of motion and gentle wrist range of motion of the wrist, along with six-pack hand exercises. We will also add gentle thumb, active range of motion, and a pain-free arc. And the big thing that we don't want to do is encourage that hypermobility of the MP joint. And so when we do that, we try to encourage them when they go into extension to keep the tip of the thumb slightly bent. So that will isolate motion of the abductor pollicis longus versus the extensor pollicis longus. Because the extensor pollicis longus has been kind of working overtime before this because the CMC joint has lost its ability to do the work. And so the MP joint has kind of learned to become hypermobile already. And so we discourage that in the therapy. So even though we are talking about rehabbing the CMC joint and that new joint that's put in there, we really are taking care of the MP joint during the rehab process also, because maximum strength, maximum pin strength cannot be achieved when the MCP joint collapses into hyperextension. And so whether there's been an MP joint volar capsulodesis done in conjunction with the CMC arthroplasty or not, we still want to take care of the MP joint so that we can help them get that stronger pinch strength back and grip strength back as we progress them. So at 6 weeks, typically we'll see the patient on that first post-op day, and then we'll see them back again at 6 weeks post-op. At that time, we'll begin some gentle passive range of motion. And again, sometimes we're trying to encourage that CMC abduction and CMC extension, but we don't want to do that and compromise the stability of the MP joint in doing so. So we want to be a little bit careful on where we place that extra pressure so that we're not putting any stress through the MP. At 6 weeks in that same visit, we'll add some isometric strengthening in a pain-free range. We'll use a tennis ball to help. Support the CMC and the MP joint when doing these. And we'll also begin strengthening of the first dorsal interossei using a rubber band. We will add the progressive therapeutic putty, and again, when we're strengthening the thumb, we really try to discourage strengthening of the extensor pollicis longus. And so if we have them place the progressive therapeutic putty on the proximal phalanx and not the tip of the thumb, they'll do better with avoiding that hyperextension of the MP joint. So we'll give them this specific home program and encourage them to, gradually work into that resistive exercises, 3 to 5 minute sessions 3 times a day, and progress as tolerated. We typically don't see patients back on week 8 unless they're having trouble. We'll oftentimes nothing's really changing in their home program. We'll have them continue to wean out of the splint, but that starts at week 6. They begin to wean out of the splint at week 6, so we'll encourage them to continue to wean out of the splint and just to use it for heavier activities so that they don't overdo things, and continue to gradually strengthen the thumb. And at 10 weeks, they're resuming full unrestricted use as tolerated. Our goals are to decrease the thumb pain, increase power grip and pinch strength, and improve their functional activities. So in conclusion, we use protocols that guide our patients' rehab and modify it depending on how they are doing. We want to strengthen without pain, discourage hyperextension of the MP joint, and really most patients are very happy with the results of this surgery. They will continue to show improvements in strength and function for several months.